Hey guys, I actually have a real clinical case that I would like to present from clinical that I encountered recently to discuss infection in the pregnant woman. So this patient was a Gravida 1 Para0 presenting to the office at 9 weeks and 2 days gestation to establish care for her pregnancy. So her chief complaint was that she was presenting with amenorrhea and 2 positive urine pregnancy tests at home. After review of systems, history, and physical assessment, it was all determined to be pretty unremarkable other than history of a previous trichomonas infection 1 year ago that was treated. So her EDD put her due in February, and her current gestation was found to be approximately 9 weeks and 2 days. She denied any episodes of spotting or cramping, no symptoms of threatened abortion, was not using birth control. Around the time of conception, she was not using birth control, and she said that this pregnancy wasn't exactly planned, but she was feeling excited about the addition of a new baby, and she was feeling supported by her long-term boyfriend at the time. She reported breast tenderness and nausea that would start in the morning, and she said that those both started about 2 weeks ago, and she reported that the nausea usually goes away after she eats breakfast and denied vomiting. She denied any discharge, gynecological concerns, or discomfort, or any other concerns really at this time. Again, pretty unremarkable first OB visit. So her chief complaint actually had nothing to do with her infection, which is why I chose this patient, because I think it makes it a particularly interesting and good example of what can be caught just in a routine prenatal appointment. So this patient was up to date with her PAPs, and her PAP and pelvic exam were deferred until 6 weeks postpartum per her request. There were no abnormal physical findings on her general assessment, like I said, and we did also order a routine OB number 1 prenatal panel, and a urine was also sent for culture and for gonorrhea chlamydia testing, all the routine testing that you would do with a normal OB visit. And so then we also gave her prenatal education that was based on her gestational age, and we sent her on her way. So, excuse me, the patient comes back a few days later with, the lab results come back a few days later, and they were pretty unremarkable other than the patient was positive for chlamydia. So the patient was, of course, called with these results, and my preceptor actually had me call the patient just to do this counseling and give her the information because she thought it would be a good opportunity for me. So the patient was unfortunately surprised by the diagnosis of chlamydia, and she was asking how you can get it. So I counseled her on some things. I just informed her that it is a common sexually transmitted infection that can infect both men and women, and meaning that it's passed by having vaginal, anal, or oral sex or sexual contact with someone who has chlamydia. And people can have symptoms, or they can often have no symptoms when they have it and may not know it. So the patient also asked me if it was possible that it would go away on its own, and I let her know that no, unfortunately, it doesn't, and that she would need to be treated to get rid of this infection, and that it was important for her to do that because it can cause serious permanent damage to her reproductive organs if not treated, and can also have adverse effects in the current pregnancy, such as preterm birth, and even also the possibility of passing pneumonia or an eye infection to the baby if she has an active infection at the time of birth. So unfortunately, no, not going to go away. So we kind of talked about that a little bit, and then after the patient understood, she agreed to be treated. And after verifying she didn't have any allergies, I called in a prescription for her to her pharmacy for azithromycin 1 gram orally in a one-time single dose. I also counseled the patient that it would be important that she takes this medication as prescribed, which would hopefully be easy for her because this is the dose regimen where it only requires 1 dose, which usually means that the patients will be able to adhere to this regimen a little bit easier because it's 1 pill that you take and then you're done. But I did counsel her that she would need to take it as prescribed and that she shouldn't give it to anyone else or share it with anyone else, which is kind of hard to do because there's 1 pill. But let her know that her partners and their partners would need testing and treatment as soon as possible And I encouraged her to have a very open and honest conversation with her partner about this, because obviously someone had been unfaithful, because this was a recent acquiring of the infection, and that it would be important to have that conversation, also to make sure that she, and if she had other partners, that they would get treated, or if he had other partners, that they would get treated, and let her know that it was super important for that conversation to happen, because she was feeling reluctant to have it. I also made sure that she knew that reinfection could occur, and she should wait until 7 days after completing this course of medication before she could have sex again with any partners, and especially that she would also would not want to have sex with any partners that have not had treatment yet, and that they would need to wait the 7 days after that dose as well if they're doing the 1 day or the 1 dose regimen. And I let her know that her partners could go to the local health department for this treatment and testing, and that was per the recommendation of my preceptor. They could, could call in a script for the partners, but they said that they usually just direct them to go to the health department. So that is what I instructed her to tell her partners to do. I also let the patient know that if she develops symptoms after treatment, that she should return to be reevaluated as soon as possible, regardless of treatment, because the infection may not have gone away, or she may be reinfected, and we need to address that. So I, of course, gave this patient opportunity to ask questions, and she verified understanding, and she was in agreement with the plan of care by the time we got off the phone. So after talking with my preceptors, and they showed me the recommendations per the CDC to follow for chlamydial infections, and so her plan would be after treatment and counseling that she would have a test of cure done, so she would come back again to make sure that chlamydial eradication had occurred within 3 or 4 weeks of this treatment that we were giving her. And then she would need to be tested again 3 months after treatment as well, to check again to make sure there is no reinfection. And then per my clinical site procedures, they said that they would also make sure that she is tested again in the 3rd trimester with her GBS swab to ensure that she did not have any reoccurrence. So, thank you.